Okay, this is going to be your video lecture for Chapter 40, Spine Injuries. Welcome back. Hope everybody's doing well today. Let's introduce the chapter. So, about 17,900 people sustain spine injuries in the U.S. We're going to talk about it. We're going to talk about the most common cause, and which they list several here: motor vehicle collisions, falls, penetrating injury, sports, and other. We're going to talk about spinal cord injuries and how they can lead to permanent disability. We'll talk about the potential for spinal column injuries exist, restrict motion of the spine, first obviously manually, and then to determine the need for spinal motion restriction. We're going to talk about the MOIs that would suggest that you need spinal restriction. Cervical spine, delicate, more prone to injury. We'll talk about the risk factors for injury of cervical spine. Not all patients with head, face, neck trauma have spinal column or spinal cord injuries. We need to understand that. Let's look at the AEMT and do a review here. The central nervous system and the peripheral nervous system, they communicate with one another, and they do that through these motor neurons that exit the spinal cord from the anterior surface. We have sensory neurons that enter the spinal cord from its posterior surface. It's kind of like a highway of information, southbound and northbound. Gray matter and white matter. So what does it do? It allows nervous signals to be transmitted up and down the spinal cord between the brain and the peripheral nervous system. And the spinal cord, if it's completely severed, the communication from the point in the cord downward ceases. And that is the problem, isn't it? Here's an image of the brain. You have the cranial nerves. Here's your spinal cord here. And these information goes down the spinal cord and back up. So the central nervous system consists of the brain and the spinal cord. And the peripheral nervous system consists of everything outside of that. All nervous tissue outside of the central nervous system. We have efferent neurons. These originate in the brain or the spinal cord, and they travel to something known as effector cells. So we have a few of those to talk about. We have afferent and efferent. Afferent, they sense stimuli through the body. They initiate signals that travel towards the brain or the spinal cord. Compare that with efferent. That's divided into the autonomic and voluntary divisions. And the autonomic nervous system consists of the sympathetic and the parasympathetic division. So when signals are disrupted to and from the brain, obviously function of the body is going to be affected. Nerves do not have the ability to regenerate. So when these injuries occur, they are permanent. The brain and the spinal cord, their job, right? Their function is to protect. The skull and the spinal column's job is to protect the brain and the spinal cord. So when significant forces are applied, the brain and spinal cord are what? They're suspect to injury. So we have the spinal column. It extends from the base of the skull to the pelvis. There's 33 vertebrae, and they're separated by these intervertebral discs. They're very fibrous, and there's a hole through the center, and that's called the vertebral foramen, and that's what houses and protects the spinal cord. And so here's those discs here. It's an image of that. So we have the cervical spine It's considered C1 through C7, the thoracic T1 through T12, and the lumbar L1 through L5. Then you have the sacral and the coccyx. So we have muscles and ligaments that support and hold the spine in position. They allow for movement. We have the cervical spine injuries are where they're most prevalent. The weight of the head causes that hyperflexion and hyperextension, rotation when forces are applied to the body. Spinal cord begins at the base of the brainstem and continues through each vertebrae to L2. Each vertebral disc have nerve roots that extend from that spinal cord to the neural foramina, and muscle functions result from these nerve impulses that go through there. Nerve impulses, they travel to the diaphragm by the way of the phrenic nerve, and we can find that phrenic nerve anywhere from the C3 to the C5 range. And so that's why it's important. Obviously, if you have an injury to C3 to C5, those are going to be bad because it's going to affect breathing. Remember, the diaphragm is the largest muscle that we use for breathing. Reflexes. So they're defensive mechanisms that assist us in preventing injuries to ourselves. Actions that result from the nervous stimulation within the spinal cord, not the brain. That's pretty cool. I mean, if you think about it, the brain doesn't have to generate that response for you to move your hand from a hot stove, or when that reflex hammer hits your knee and your knee lunges forward. That's part of that. Nerve roots of the spinal cord allow reflex actions to take place. And that's exactly why they do that reflex hammer, because they're checking your efferent, afferent pathways. So ascending spinal tracts, they carry impulses from the body to the brain. They carry sensations like light touch, pressure, temperature, and vibration. Descending spinal tracts carry motor impulses from the brain to the body, and they control muscle activity and tone. So not all of the injuries to the spinal column are going to result in a spinal cord injury. I mean, it really takes a lot of energy to cause a spinal cord injury. In the appropriate patient, utilize spine motion restriction precautions to help limit movement of the spine, so that movement does not worsen that injury. So if you suspect it, though, you have a high energy mechanism, then we will do that. So mechanisms of spine injuries, right? Compression, hyperflexion, hyperextension, rotation, lateral bending, distraction, or penetration. So flexion injury, which is like right here. That's a person maybe who's fallen in the staircase here with one of the steps directly striking the lower back, and that leads to that flexion injury. We have the compression injury. A person's head strikes a surface in an upside down position, so the whole weight of the body is coming down, and that can lead to that compression spine injury. Here we have the hyperextension injury. This is a person that's sitting on the driver's seat of a car. They get that sudden jerk from the backside of the car that causes that sudden extension of the spine that leads to that hyperextension injury. A distraction injury. A person is hanging in the air right here with a rope around their neck tied to the ceiling. this downward weight of the person leads to a distraction injury. We have a flexion/rotation injury right here, and so rotating the lower part of the body in one direction and the upper part in the opposite direction. Then we have the penetrating injury, so a pointed or sharp object that actually penetrates the spine. So a spinal column injury versus a spinal cord injury. So a spinal column injury, you have damage to the muscular skeletal structure of the vertebrae or even the ligaments of the spine. Remember, that houses the spinal cord. So you can have damage to that without actually damaging the spinal cord. But if you do have a spinal cord injury, a damage to the spinal cord itself, that patient is going to present with some neurologic dysfunction. So we have primary injuries, secondary injuries, and spinal cord concussion. So a primary injury results in the compression or shearing of the cord. It's a direct result of the MOI. The secondary injury occurs after the initial injury, and this is where we have the edema or the swelling, the ischemia, the movement of bone into or against the actual spinal cord. Then we have something called spinal cord concussion, and this is a temporary disruption of the normal spinal cord function distal to the site of the injury. This is just like it says, it can be temporary, right? Once the swelling goes down, the neurological dysfunctions return. Or you can have a complete spinal cord injury, and this is the total disruption of the spinal cord, the total loss of neurologic function distal to the injury site. Swelling can also occur, excuse me, as swelling subsides, again, some of that function returns. You have an incomplete spinal cord injury, and in these, the injury involving the portion of the spinal cord, we could have something known as anterior cord syndrome, central cord syndrome, or Brown squared syndrome. Let's talk about those. So in central cord syndrome, this results from an injury to the central region of the spinal cord. And anterior cord syndrome results from the injury to the anterior cord. And then we have Brown squared syndrome, and this results from the injury to one side of the cord, either right or left. And we can look at these types of injuries and we can compare the signs and symptoms with these injuries as well. We have spinal shock. So spinal shock is a concussion-like injury to the spinal cord that causes neurological defects below that level of the injury. So we can have loss of muscle tone, paralysis below the level of the injury. Both smooth and skeletal muscle tone is lost. And that's important, right? Because this is where we're going to get hypotension from. Also with that, hypothermia and loss of bowel or bladder control. If enough vascular effect, again, what I just mentioned, hypotension occurs, neurogenic shock. So neurogenic hypotension secondary to spinal shock. And so we have that dilation results in relative hypovolemia, and that patient is going to become hypotensive. So this is a type of distributive shock. Compensation is lost due to that spinal injury. So that sympathetic response that we should get, we're not receiving. And that is why your heart rate here remains in that normal range. We're not getting that release of epi and norepi. And so in neurogenic shock, if we look at the skin condition, we have pale, cool, and above the level of the injury, flushed and warm below the level of injury. If we're comparing that to hypovolemic shock, well, hypovolemic shock, all the skin of the entire body is pale and cool. Also, again, bradycardia or normal range with neurogenic shock versus remember, regular hypovolemic shock, you're going to compensate, right? So your pulse rate's going to be higher. It's important to understand those differences. If you get a motor vehicle collision, you get somebody, you're checking out, their skin happens to be warm in that area. You don't see them sweating. They're not tachycardic, but their blood pressure is in the tank. That should start, cluing you in on a spinal shock type event. We've covered this in previous. I don't think we need to. We understand the primary assessment. Here we have that manual stabilization of the head and neck because we suspect a spinal injury. You want to make sure that you're maintaining that spinal motion restriction precautions of the head and neck. And do that until you get a commercial immobilization device there to restrict that motion as placed on the backboard. When we have someone with a spinal injury and the primary is complete, and that primary includes that C-spine, manual C-spine control, right? And we're moving now to the secondary assessment, and we're doing our reassessment. We're going to reassess for motor function and sensation in all extremities. And that's what they're doing here. You're going to assess flexion, assess extension. You want to assess for finger abduction and adduction. You're going to assess the wrist and hand. This is where you're going to have them push your hand up and then push your hand down. You're going to check for that plantar flexion. Dorsal flexion, and pain response. So when we talk about spinal motion restriction, not all injured patients require spinal mobilization, right? You want to consider the MOI and the indication for spinal motion restriction and signs and symptoms. You're going to assess their level of responsiveness. You want to ask the patient if their neck or back hurts. You need to palpate the entire spine and see if it's tender. And you need to assess for motor and sensory deficit. If anything's abnormal here, then yes, we're going to provide that C-collar and backboard. You should go through this image here of the spinal motion restriction decision protocol. Be aware of that. We all by now should understand how to size a cervical collar, so please review that. Be aware that distracting injuries make spinal injuries less sensitive, right? Because of pain in other areas. Always err on the side of caution if unable to determine the need for spinal restriction. Let's look at these current trends. These are important. De-emphasize the use of both short and long backboard as treatment for suspected spine injuries. Right? We used to immobilize every single person out there if they complained of neck pain. Now it's important to do an assessment, right? Palpate the cervical spine. If there's not pain directly over the spinal column, like we just talked about, then there's no need to do that. We find that we are a lot of times providing more harm than good by mobilizing people. All right. And I think most of all of this is stuff that you're familiar with. Should review, again, the spinal motion restriction for adults and infants. So that's going to be it. I will post this video and we will see you in class.